therapist over at Stroud Hospital. Is that correct? He's going to talk to you guys a little bit about ABGs, VBGs, things like that. It's really important to take a listen and understand because there could be test questions about interpretation of those results.
Could be.
Probably, most likely.
Could be, yeah.
Hint, hint. Okay, whenever you're ready, Glenn.
Hi, I'm Glenn. I've been a respiratory therapist for about 10 years. I also have attained some extra credentials, so I'm also an adult critical care specialist, and I've dealt with ABGs for quite a while now. It's like the main part of what we do as therapists. So it's going to tell you why we need to draw blood gases. So the human body likes all things to be at a certain level to maintain something called homeostasis. Homeo means similar and stasis means stable. So if it's not right there at that level, then things get funky. So the main thing that you're always looking at in a blood gas is called pH. And it is the log of hydrogen ions in the body, in the blood. pH actually stands for the potential of hydrogen. So pH in the body should always be 7.35 to 7.45. If it's less than, then it is considered acidotic. And if it's greater than, it's considered alkalotic. Oops. So the body's trying to maintain a homeostasis at a pH of 7.35 to 7.45 at all times. It does it through two different variables. One is through the kidneys and one is through the lungs. The lungs manages it through CO2 and the kidneys manage it through bicarb. And that works through something called a Henderson-Hasselbalch equation, which is pretty complicated, but and I didn't write it out, but what it kind of looks like in the body is you've got H2 CO3, and it goes like this in a constant. Okay. On the other side of this, we're going to call this the kidneys. And this is representing that it's constantly going back and forth. And this is known as carbonic acid. Okay? Carbonic acid is a byproduct of digestion and from everything that we eat and drink, and our body has to buffer out the acid out of our bodies. And whenever it goes to the lungs, it's converted to water and CO2. Then it's exhaled. That's getting rid of acid there. When it comes over here to the kidneys, it's converted into a hydrogen ion, which is going to bind up with another like salt or chloride or something like that in the body. I don't understand the kidneys very well, but that's what's going on there, and bicarb. And these are the things that you're looking at on the blood gas right here. And the body's constantly getting rid of that acid in that body to maintain homeostasis. So, let's see, erase. Everybody good and confused? Okay, good. That's just some of the background on it. It's not really that important to probably what's going to be on this test. So the two types of blood gases there are that they draw in the hospital are VBGs and ABGs. I'm going to write up the values for VBG versus ABG, talk a little bit about it. I know this one by heart. I have to look for the VBG one here in a second. 4, 5. This is pH. $1,000. PaO2 should be 82,100 in a perfectly healthy, normal adult. Bicarb, anybody know that one?
It's like 22 to 28.
Some books say 22 to 26, some say 22 to 28, but yeah, that's pretty much it. And then base excess goes, it just follows and tells us which direction, is it more metabolic or more respiratory. And so this is the kidney makeup of it here with the bicarb, and then CO2 is the lungs making up of it. And then SO2 should be 90% or greater. Let's see here. Okay. Now VBG can run a little more acidotic, so it's going to be 731 to 7.41 and still be considered normal. PaCO2 can be 41 to 51 and still considered normal. PO2, which actually, that's wrong there. It's PVCO2 and PVO2. Should be 30 to 40. That's pretty dramatically lower than a PaO2.
What is BPG?
BBG, it's a venous blood gas instead of arterial blood gas. Bicarb pretty much stays the same at 23 to 29. And SO2, SVO2 can be 75% and still considered normal. So why would you want one over the other? VBG versus arterial blood gas.
Well, the arteries have oxygenated blood and the veins have unoxygenated blood.
Right?
Right? Is that basically it?
That's basically it. So for most things that we do in the hospital, we're not needing to see the exact oxygen in the blood. And really, if we're looking at something with, I would say 50% FiO2 or lower, we don't really even need the oxygen. We can measure it off the pulse ox and manage the patient's care from there. We want to avoid ABGs when we can because there's much more limited access to get an ABG versus getting a venous gas. For a venous gas, you can get that blood anywhere you get blood. And if you mess up a vein, it's going to be up there, another one somewhere up on the arm that's going to work. If you mess up an artery, you may cut off blood flow to whatever side you stuck. So there are a very limited number of sites that can be stuck. The first choice is always the radial. And you want to do a positive Allen's test to determine if lateral blood flow is existing between the radial and ulnar arteries down the hand. So you basically hold both arteries down and then, or hold the radial artery down, and then you look for return of blood flow in the hand to pink back up. And if it doesn't pink back up, there may not be collateral blood flow. So if you messed up that radial artery, you may cut off total blood flow to the hand, potential of that limb having to be cut off in the future. You can go ulnar too, pretty rare. Next option would be brachial. Up here, we don't like to do that because then that's even more limb down here that may have to be cut off if I were to mess up a brachial artery whenever I stuck it. So, then next is femoral. I've mainly only ever done these in coats, but in rare cases where you got like limb restrictions on both arms and it just has to be gotten, sometimes you got to go for femoral. Most hospitals don't let you do it, but the occasional one does. And then the very last one is pedal. No, we can't get the carotid. That would be fun though. Pedal is a lot of times used in burn units, whenever most of the body's skin has done been burnt off all the way, 90%. Normally you had shoes on, so there's a little bit of skin left down there to stick. I've done a couple pedal gases whenever I worked neuro on some really bad diabetic patients where their skin was just like peeling off their arms and there was still some good skin intact on the pedal. You just feel that pedal pulse down here and you can stick that just like you do the brachial or radial. So yeah, if you're not needing to know the exact PaO2, because there's such limited options here on arterial and where to get it, then it's perfectly acceptable to get VBG and probably the better thing to do. You see the values are a little bit lower on the pH. That's because the blood has been consumed and used through like cellular reproduction and digestion in the body, and it's needing to come back up and be reoxygenated. And it's built up some acid in the body, so the CO2 raises up a little bit. It needs to go through that process of ventilation. But there's a set of normals here that's just a little bit lower than what an ABG is. But both of them give us plenty of data to work off of and use clinically. Okay. Is that all good and confusing? All right.
Makes sense to me.
Makes sense to me.
So, let's do the fun of interpreting some of this.
Okay.
When in Rome, do as the Romans do. That's what I was told.
I just learned what Rome meant.
Yeah.
Without hard laugh.
Rome stands for respiratory. It's probably a bad way to write this. Is opposite of the pH. Because remember, everything's always about the pH. Don't look at anything on a blood gas until you've looked at the pH. I about to spell it wrong. Metabolic is equal. So whichever way that bicarb's flowing, the pH goes right with it.
Which one's the bicarb?
The what?
Which one's the bicarb?
The HCO3. So, yeah, I did that bad. Let me redo this. I don't do this very often, so.
You're doing great.
Okay, good. And I'm very technologically challenged, so
Same.
this thing is really giving me fits. Respiratory opposite. CO2 is our respiratory. Make that a little more clear there. So, pH, if it's going up, what is it becoming? Alkalotic, perfect. Okay, so if respiratory is the opposite on pH, what is CO2 doing if it's going alkalotic? Yep. CO2 is going down. If pH is going down, because respiratory is opposite, CO2 is coming up. So then we flip that for metabolic equal. Bicarb. Oops. Dummy. Okay. If pH is going up, it's equal. What am I touching? Okay. Bicarb is going up. And if pH is going down, bicarb is going down. That makes sense? Alright, awesome. So, let's name these 4 conditions here real quick. A basic condition. So pH went up, CO2 went down, and that would be our primary problem. So it's gonna be respiratory
Acidosis.
That's alkalosis.
alkalosis. Yes,
The next one is acidosis.
right. Now metabolic, we got bicarb, pH is going up, bicarb's going up, so now,
Is it metabolic alkalosis?
exactly.
You retained it.
Keep it in for 2 more days. Or are we done?
So pH is going down, bicarb's going down.
Alex,
Acidosis.
yeah.
Hopefully y'all can read my cursive.
We didn't learn that in school.
I did.
Well,
I did.
I'm old, so.
Young children don't know.
Mhm.
Just go, you go.
Okay.
Yeah, just because you're older.
Well,
Do what?
that is fun.
Reading?
Y'all wanna try and interpret some of them?
Sure.
Yeah.
All right,
It's 35.
so. What's the first thing we're gonna identify no matter what?
pH.
Okay, cool.
This is our view.
Well, feel free to participate.
I would participate.
You have a line on the board.
It's okay.
Are you happy now?
I am, thank you.
Okay. So, we got, where's the question for this one?
The ones I printed for you?
Okay. You're called to see a 54-year-old lady on the ward. She is 3 days post-cholecystectomy and has been complaining of shortness of breath. Her ABG looks like this.
Cholecystectomy is just your gallbladder out.
Oh.
Yeah.
Because if your body pH is lower, it's acidic.
So, first of all, are we acidotic or alkalotic?
Alkalotic.
Okay, awesome. That might even help to like write out the side. We're alkalotic. And do y'all have the values memorized of what's gonna be out of order here?
Should.
So we're gonna ignore oxygen for the first part. That's like something that's gonna come in clinically later. All we're looking at is CO2 and bicarb. And some of these study ones I'm seeing out here, they totally don't even put oxygen in your equation to make it easier for you. But is CO2 high or low right now? It's low. It should be 35 to 45.
Okay.
And is bicarb high or low or normal?
Normal.
Normal. It's on the low side of normal.
22, 28.
So, our main problem here, if we were to interpret this, is a respiratory,
So if the PCO2 was normal and the bicarbonate was low or high, then it would be metabolic alkalosis.
yeah.
Okay, hold on.
That was.
How do you differentiate if it's respiratory or metabolic?
Base excess and seeing which one is like more dominant than the other.
Okay.
So like on this one, base excess was -1. Normally, if you're going to the positive, I believe, that's gonna make it more metabolic than respiratory. But, with this one, it's pretty easy. This one isn't a mixed acidosis or alkalosis. This one is solely respiratory alkalosis. But there is something else fun going on with this patient right here. So, a 54-year-old should not have a PaO2 of 56. So they're hypoxemic. It says this one has type 1 respiratory failure, where PaO2 is low and CO2 is low. So the patient's blowing off a bunch of their CO2 and they got a high respiratory rate. Considering that they're post-op and now they've all of a sudden become shortness of breath, I would most likely think either PE or pneumonia, but they said it could be PE, pneumonia, asthma, pulmonary edema, pneumothorax, or some severe atelectasis going on.
That's all of it.
Basically, it could be anything acutely respiratory going on with that to cause that PaO2 to drop like that. Okay. The next dude. There's only 10 of these. But it's gonna kind of work us through all of the metabolic respiratory.
Okay.
And give us an example of each. Question 2. You got a 75-year-old gentleman living in a community that's being assessed for home oxygen. His ABG is as follows. Sorry. Oh, Lord. Lord. I hadn't even cussed yet.
It's coming.
And these questions I printed off, they gave the values in kilopascals, so I had to go back and convert them all into millimeters of mercury, and where we
He
could all
said to me, it was
understand
his
it.
idea.
Okay. PO2 is 60. PCO2 is 7. Bicarb's 31. And base excess plus 5. Okay. So, look at pH first.
That's
normal.
It's on the lower end, but it's still not.
Yeah. So that also clues you that it would be going more towards acidosis than alkalosis, because it went to the lower end of normal. But yeah, there's some compensation going on here for whatever's going on up here. So yeah, there's metabolic alkalosis in the equation. But we're normal here, so whatever the condition's gonna be, it's gonna be considered compensated. What else is out of normal?
The CO2 and PCO2.
And bicarb, yeah.
What is BE?
Base excess. It kind of points the direction of which way the is it kidney or lung?
So if it's negative, if it's like in the negatives, it's kidney, and if it's positive, it's in the lungs.
I believe so. Don't quote me on it.
Ramsey said yeah.
So whatever we are, we're compensated. So we can start with that in our brains over here. It's normal. So we're not going to need to do anything major to treat this patient because they're compensated. They're fine. Because we treat the pH no matter what. Ignore PO2 for a second. We're even though we're qualifying for a home oxygen test, we're just kind of looking at acid base right now, okay? So this CO2 is high, and we got respiratory opposite, so we got a a respiratory acidosis. And like you said, it looks like a metabolic alkalosis whenever you look at that bicarb. That's what's bringing in this compensated part. Because this patient is chronically at a higher level of CO2. We know they're chronic because their bicarb elevated, that metabolic is starting to alkalose the body to catch up for chronically having a high CO2. This is a pretty standard COPD patient, and the pH is right where it ought to be, so this is what that patient lives at. This is their norm. A lot of times you'll get that gas and someone comes screaming at you, I need a BiPAP. And you're like, no you don't. No you don't.
He tells patients that. Yes, you can. You're talking.
Let's see what the case study said about that oxygen. Says this respiratory acidosis doesn't represent an acute pathology. Nothing needs to be done for this man. The criteria for long-term oxygen therapy does not meet the criteria for long-term oxygen therapy. I think that's because CMS guidelines say that a room air blood gas PaO2 has to be like 55 or lower. So like he's right there on the threshold of. The other way they would qualify him for the hospital, getting a little bit off subject, would be do a walk test, and they would walk him for, I think, 6 minutes, and if the SpO2 drops below 88%, you could qualify someone that way. But from a blood gas perspective, there's nothing you can do clinically with this. This patient is fine.
So no at-home oxygen.
Nope, not yet. They're getting there though. They need to quit smoking, for sure. But don't we all? Okay. Ready for number 3?
Yeah.
Are y'all having fun?
Yeah.
Yes.
Good.
Clear as mud?
Yeah.
Okay, good. Clear as mud? You haven't heard that? Oh my God, you're so
All right, we got a 64-year-old gentleman. He's got a history of COPD with worsening shortness of breath and increased sputum production. Got a pH of 7.21. Is this good or bad?
Bad.
Okay, is that acidotic or alkaline?
Acidotic.
Okay, awesome. That's what I like to hear. Is PaO2 is 54. Sounds like he gets home oxygen if we're on the last dude. His PCO2 is 64.
Oh, my.
Bicarb is 29.
Ooh, we're in the very end of the range.
It's trying. It is trying. Basic success was +4. So what is our main problem?
Respiratory acidosis.
Okay, awesome.
I've been holding on to that one. But now we can go back to pH is low.
How do we fix a respiratory acidosis?
We fixed it.
We find a way to lower the CO2. So we're
With
gonna
BiPAP?
increase, what, that could be a vent, could be, one of the thresholds for needing a ventilator versus a BiPAP is a pH of less than 7.25. But you also have to clinically evaluate, is this patient still alert? Are they still talking to you? What's the Glasgow coma scores? You know, if they still look like, oh, they're still talking a little bit and they're not just completely obtunded, we would still BiPAP this, most likely. If they're obtunded, not maintaining the airway, automatic tube. But pH of less than 7.25 is like a real quick way to get yourself an ET tube in the hospital. So this one, they labeled as type 2 respiratory failure. Difference between type 1 and type 2 is type 2 involves your CO2 raising up. Type 1 is you're just hypoxemic. It also talks a little bit about the complications of oxygen administration in this patient. I'm gonna come back to that after we finish all these case studies real fast. Cause I've got a small rant on oxygen. So yeah, we identified respiratory acidosis and it's not compensating. And we need to get some ventilation going.
Do 5 of them.
Do what?
Do only 5 of them.
I'm not taking too long?
No.
He was so excited. to
I know. Ramsey's the one that said it.
Oh no.
Well,
Me too. Ramsey told me.
was that 3 or was that?
That was 3. Wasn't it?
Alright, let's find DKA. Y'all need to know about DKA.
Yes.
That's your most common crap in the hospital.
What does that have to do?
You'll find out.
I had a girl in the training where she was going into nursing school. She kept asking me the same questions over and over and over and over. Well, because we had someone
We had
that was there for hypophonia, and then we also had a DKA.
Okay. We'll do 3 more, and that gets us into the metabolic side.
Okay.
This one's fun. 67-year-old man with a history of peptic ulcer disease presents with persistent vomiting. So, when you're vomiting up stuff, you got muriatic acid, and you're gonna be losing sodium, chloride, all the electrolytes. That messes with your pH right away. So let's figure out what that's gonna do with some persistent vomiting. pH is 7.56. Is that acidotic or alkalotic?
Alkalotic.
That's a good way to remember it.
PaO2 is 80. PCO2 is 37.5. Bicarb is 31. So we're alkalosis. $35 to $45, so that's within normal range, right?
Yes.
This is not, right?
No.
So this is our problem.
Yes.
Yeah.
Metabolic alkalosis.
Looky there.
Let's,
It got exciting, didn't it?
let's see what it says about puking.
Puking?
Yeah.
I don't like puking.
Uh, persistent vomiting, gastric outlet obstruction or pyloric stenosis in a baby, diuretic use, and massive transfusion can all cause this metabolic alkalemia here. Yeah, he lost a bunch of fluids and
Okay.
Can over-ingestion of Tums also cause metabolic alkalosis?
yes, because the calcium is basic and or calcium carbonate is basic.
Yeah.
Speaking of overdose, that's who we got for our next one. Isn't that interesting?
It's like you know these, and you're cheating.
Cheater.
I didn't even get to see the paper.
You cleaned it out.
She actually didn't, this girl, she didn't overdose on Tums. She overdoses on aspirin. So that's pretty common, and I actually didn't know what that would do, because you see it a lot, but apparently it can make for a pretty scary situation. So I found this one really interesting. So, I think boyfriend watches girlfriend take a bunch of tablets she shouldn't have took, turns out it was aspirin, runs her up to the ER thinking she's gonna die. You don't think she's gonna die because it's just aspirin, but Turns out you might actually can. So,
Is it good?
her first blood gas looks like this.
First, we have a couple.
Yeah, so that means we had a decline. pH is 746. PaO2 is 94. Perfect. And PCO2 is 26. Bicarb is 22. Alright. So what we got?
Respiratory alkalosis.
Yes.
Is that your question?
Yes. Respiratory alkalosis.
Yeah, but you
Good job.
It's barely an alkalosis, but they're having to monitor for overdose here, so a couple hours things go bad. And our pH turns into 7.15.
Uh-oh.
Oh.
And remember when I said
They're on the bed now.
They're on me.
below 7.25 can automatically get you an ET tube, so now they're gonna have to evaluate, is this girl tuned, like what's going on? PaO2's went down a little bit, she's obviously maintaining an airway, I can see that from this gas because her oxygen is still 83 in the blood, so that's good for her. She's still trying really hard because CO2 is 24. She's hyperventilating, trying to compensate for whatever damage she's now done inside her body. Here's our big shocker here. Bicarb's dropped down to 9.
Oh.
That's an acute kidney injury right there. So she is tore up her kidneys. And what would that be considered?
Metabolic.
Main problem is
It's acidosis.
acidosis, perfect, okay. And who's more out of normal here?
The non-metabolic.
Well, how we know that this is more out of normal is because the problem is acidosis. Respiratory is going alkalosis right here, trying to compensate for the problem, which is acidosis. Our problem is always towed to us in the pH. So now we have a metabolic acidosis, and hopefully this girl lived. I don't know if she did or not.
She definitely got 2.
Most likely.
Yeah, that's a little close to home.
Now this next one you think would be tubed, but it's probably like 75% of the time they're not. So we got a pH of 7.12, PaO2 of 86, PCO2 of 24. So it looks pretty similar to the last one. Bicarb of 9. What's our problem again?
Metabolic acidosis.
Perfect. And let me tell you about this guy here, because this is what you will encounter a lot in your life.
So you said that metabolic is equal to the pH, so like metabolic will be if the bicarbs drop, the pH drops? Or was that something different?
Yep.
Okay,
Metabolic equal. If the bicarb
Respiratory.
drops, the pH drops.
respiratory is if the pH goes up, the CO2 goes down.
Right.
Okay.
Perfect.
Okay. Okay. Yeah.
We did wrong.
Probably forget it later on, but that's okay.
Just get done.
This one is actually a little boy. A normally fit and well 11-year-old boy presents with diarrhea and vomiting. He's complaining of nonspecific abdominal pain. The VBG shows this. Other values that you should know about this is his potassium is all of a sudden 5.5. His glucose is 395. 11-year-old boy with a glucose of 395 and no other history. You know automatically what you got right here.
Diabetic
You got,
ketoacidosis.
yeah, you got acidosis, high blood sugar, it's DKA. It says priorities include fluid resuscitation, and insulin, administration. With DKAs, you just mainly gotta watch their airway. A lot of times they can hang out down here in the 7-1s for quite a long time and keep on compensating with like 2 small breathing patterns, breathing in deep and, but they are in dangerous territory for sure. So we went over some respiratory and some metabolic stuff, and I'm just gonna give you a little rant on oxygen, the dangers of oxygen use. And then I'll leave you all alone. Hopefully we all learned something today.
Any questions about ABGs, BBGs?
I actually think I understand that.
A little better?
Yeah.
Lots of
Good.
good.
A lot better now.
Good.
Look at you
I
go.
could talk about pH all day long. Hit me with it and I'll make up an answer. So yeah, ignore that oxygen whenever you're going to interpret a gas at first. Just completely ignore. Come back and look at it later. Look at the full clinical picture. But now we're gonna look at the oxygen for a second. So, we're gonna stick with primarily ABG because the oxygen on the BBG does us absolutely no good. One of the primary reasons that we have done ABGs over the past 2 years during COVID is to determine if we had an acute lung injury or ARDS, and they are defined as an ALI, is an acute lung injury, is a PF ratio of less than 200. This patient's gonna need BiPAP, maybe not vent all the way quite yet. What people died of in COVID was ARDS, and that's when the lung gets a little bit worse. And it's a PF ratio of less than 100.
What does PF stand for?
Good question. PF is the PaO2 divided by the FiO2 of whatever you drew. That blood, if they're 50% on the ventilator, you take that, you divide whatever that blood gas, the PaO2 came back as, divided by the FiO2. So that's big reason for ABG versus VBG again. We need to see if we got an acute lung injury or ARDS. And that changes our care big time. I know y'all's books, pretty much everybody's books these days, ran about not giving excess oxygen to COPDers. And it's partially true. I've seen it a little bit in the real world, but not as dramatic as what the book makes it. So we like to maintain our COPDers at SpO2s of 88 to 90%. That's why that guy earlier in the gas, whenever we're looking at that PaO2 of 60, that COPDer, perfectly okay for him to be down there at a lower state. So whenever the oxygen's a little bit lower, it reminds, the nervous system reminds the lungs to breathe and blow off some of that CO2 because they're chronically retaining CO2. If the oxygen gets too high, the nervous system, the receptors in the lungs just kind of relax and they're like, oh, I don't have to breathe anymore. And that CO2 climbs on up and you get something called CO2 narcosis. Last thing here, using excess oxygen can cause something known as refractory hypoxemia. This normally occurs in FiO2s of 50% or greater. And what's going on there is the body can get used to being at a higher FiO2 pretty quickly and say, hey, I kind of like it here. And then you try and turn them down and they don't want to come back down. So now you got to pop them open with other devices, get the lungs open more. And the other thing that's happening there is oxygen is a much more dense gas than all the other gases. So normally we breathe 21% FiO2, unless we're in Colorado, and then I think it's like 20 or 19%. All right. The rest of our air is made up of lighter weight gases like nitrogen and xenon, argon. Where you start putting in heavier amounts of oxygen, since oxygen weighs more, it washes out all of the other gases. That makes the lungs more dense. That increases sputum production and decreases the lungs' abilities to clear that sputum out of the lungs. So you get something called absorption atelectasis. When the body has absorbed too much oxygen, that heavy gas is weighing the lungs down. So first thing we do, once we get someone on an event, we're trying to get that oxygen down. That is top priority number one. And at all times, we're trying to get patients under 50%, because that's when the nitrogen washout is really occurring. That's about all I got.
Cool.
Thank you.
Thank you.
Good.
Thank y'all.